ESG is endoscopic sleeve gastroplasty. By the name, people compare it to the sleeve surgery, but it is not a surgery. ESG is an endoscopy, so it's done through the mouth. It's an outpatient procedure, so we do it at an outpatient surgery center. People go home the same day. And while the patient is under anesthesia, we go in from the mouth. We do an endoscopy, but we have a suturing device that is loaded on the tip of the scope. So we get down to the stomach, and we put sutures in the stomach from the inside. So we suture the walls of the stomach together, and we make the stomach smaller, tighter, and shorter.
Hi, everybody, and welcome back to EndoCast. I'm your host, Leslie Bishop, and this is episode 30 with our physician guest, Dr. Halim Charbel, alongside his registered dietitian, Kaitlyn Cole, both from the Silhouette Clinic. We had a fascinating discussion about the very hot topic of endobariatrics. EndoCast is a GI-focused podcast for clinicians, by clinicians, presented to you by Boston Scientific. Together, we'll take a closer look at the data, techniques, and insights of endoscopy that matter most to listeners like you. Dr. Charbel and Katelyn, welcome to EndoCast.
Thank you.
I'm super excited to have you guys. We're at our national sales meeting, and we just saw Dr. Charbel on stage with a patient, and that was an amazing story. But before we get into it, will you guys just introduce yourselves? Tell me about your practice. So you can go ahead and start, Dr. Charbel.
All right, I'm Dr. Halim Charbel. I'm a gastroenterologist and a bariatric endoscopist. I did my training at Georgetown University Hospital in DC, and then I worked in Maryland. Since then, I opened my practice, my GI practice, digestive care specialists, in 2017, and then in 2019 I got involved in endobariatrics, so I opened the Silhouette Clinic, and we started offering endobariatric procedures and medical weight loss, and here we are today.
So in 2017, what was your specialty prior to doing weight loss?
I was doing GI, general GI.
General GI.
Yeah.
Okay.
Yeah.
Were you doing ERCPs or EUS or any of that?
I don't do ERCPs, but I trained in EUS, so I still do a lot of EUS along with general GI.
Okay, but it's mainly been this weight loss stuff since 2017.
Since 2019, we started.
2019, yes.
Yeah, we started. I got interested in weight loss, and then I started doing the ESGs and revisions, and then we expanded our offerings, and the team grew. We added another physician, 2 nurse practitioners. Katelyn joined, and then we added another dietitian, and now we also do medical weight loss. So we're now offering all kinds of obesity management.
Okay, so you're the perfect person for this. So Katelyn, go ahead and introduce yourself too.
Sure. Yeah, so I'm Kaitlyn Cole. I got my bachelor's degree at the University of Wisconsin in dietetics and became a registered dietitian in 2014. So it's been a little over 10 years. I can't believe it. I worked in various different fields, and then I surprisingly found my calling in bariatrics. I was working in a surgery center and decided to get a little bit more education and became a certified specialist in obesity and weight management, and got my master's degree, some coaching experience, and then we had to move. I love that job, but we had to move. And then I found the Silhouette Clinic, and it was just a perfect fit. And so I was able to bring everything that I've done in bariatrics to endobariatrics and medical weight loss.
I love it. I'm so excited to have you both here. So normally our audience for this podcast is physicians, and I'm sure we'll have a lot of physicians listening, but I actually think because of the topic, we might have a lot of patients or prospective patients. So Dr. Charbel, could you start and just explain what is the ESG procedure?
Okay, so the ESG is endoscopic sleeve gastroplasty. By the name, people compare it to the sleeve surgery, but it is not a surgery. ESG is an endoscopy, so it's done through the mouth. It's an outpatient procedure, so we do it at an outpatient surgery center. People go home the same day. And while the patient is under anesthesia, we go in from the mouth. We do an endoscopy, but we have a suturing device that is loaded on the tip of the scope. So we get down to the stomach, and we put sutures in the stomach from the inside. So we suture the walls of the stomach together, and we make the stomach smaller, tighter, and shorter. That takes around 45 minutes, and then the patients wake up. We keep them in the recovery area for a couple of hours, and then they go home the same day. And usually, compared to surgery where they have to take 2 to 3 weeks off, they take 2 to 3 days off, and they go back to work.
That is incredible. If they were to get a surgical sleeve, would they be in the hospital overnight for a few days also?
Usually they'll be overnight, only one night, but then they have to take 2 to 3 weeks off because they have pain. Like any surgery, because they go through the belly, they cut the abdominal wall muscle, so the recovery is difficult because every time you move, you have pain. Compared to the endoscopic sleeve, where we go in from the mouth, so there are no incisions and no scars. And because we don't cut the abdominal wall muscles, that issue of pain with movement, it doesn't exist. So patients have some pain after the procedure, maybe some nausea, but within a couple of days, they feel much better.
All right. So tell me about the benefits.
So when we suture the stomach, we make the stomach smaller. So it accommodates less food, so people can feel full with a smaller amount of food. So they eat a smaller portions, so they feel full faster. But also when we suture the stomach, because we suture the muscles of the stomach, we make the stomach slower. So we induce what we call delayed gastric emptying. So when you eat a meal, this sits in the stomach for longer, so people feel full for longer. So you end up feeling full with a smaller portion and feeling full for longer. And that is a great tool that helps the patients lose weight. You still have to go through the effort, you have to eat right and, do a lot of things, but now you have something helping you, so you actually have this there so you can achieve results with your efforts.
About how much smaller are you making the stomach?
So we always do the same thing, and we don't measure it every time basically, but we estimate that we make it 70 to 80% smaller.
Oh, a lot smaller.
Yes, a lot smaller, but it is not really the volume that matters the most. I think most of the effect is because of the delayed gastric emptying. So even if somebody's stomach is bigger, but their stomach is slow, they might still feel full much faster and longer. So I think it's more complex than just the volume of the stomach. Also, patients always ask about the volume of the stomach, how much smaller the stomach is. But I tell them that it's more than just the volume, it's functional.
So someone who's looking into this, I'm sure, is looking in because of the weight loss. But what are some of the other benefits outside of weight loss that you see with your patients?
So sure, people usually get to us after they've been trying to lose weight for a long time. They try diets, exercise, all that. And then eventually people do the yo-yo diets. And they lose weight and they gain it back. And eventually they get to us. They typically are patients who either don't qualify or they don't want to undergo surgery that's more aggressive. So they're looking for weight loss. But beyond weight loss, obviously, we know that obesity is a major problem. It's an epidemic, and it causes a lot of comorbidities and problems down the line. So losing weight is a healthy thing, and it helps with the metabolism. It helps with diabetes.
And this must be the most satisfying procedure for you as a physician.
Absolutely, for somebody who used to doing colonoscopies, people, they don't like coming to you, and then they just want to forget about you, so they forget your name. This one is different. So when I transitioned from doing GI to doing endobariatrics, it was great because I had a lot more satisfaction from seeing all these patients coming back happy and seeing the impact that we had on their lives. We shared stories about patients coming and telling us little things that they enjoy, that they ran their first 5K, or a patient who was able to run after her grandkids without getting short of breath, and stuff like that, things that they enjoy now, and it makes a huge difference in their life.
Do you think that there is going to be an influx of new people going into GI because of this procedure? Do you think this is going to influence people in their fellowship choice?
I think it's becoming part of the training, not for everybody, but more and more people are interested in endobariatrics. They see that as one very interesting, topic and field. It's more of a service line in, the GI training. People are, happy about doing that because they feel that they achieve good results. So there's always somebody smiling at the end of the journey. So that's really satisfying.
Yes, more than the colonoscopy, I would.
A little bit more,
guess. Yes. Okay, so tell me about the other types of people that your patients are working with pre and post procedure.
So, it takes a village to achieve some good results. And obesity is a complex chronic disease. It has, metabolic aspects, it has psychological, emotional aspects, genetic aspects, all kinds of stuff. So we obviously need more people involved so we can get some good results. So we obviously have the patients working with the providers in the office, myself, the nurse practitioners who manage a lot of the medical aspect of the disease, whether it's pre or post procedures. Many times these patients have other issues like thyroid problems that need to be addressed, or other problems. We work with their primary care physicians because we need to adjust their medications. Sometimes they have certain medications that can cause weight gain or interfere with our process. So we also work with their primary care physicians so we can adjust these medications. One of the biggest factors is working with Katelyn, with the dietitians, because that's extremely important. as I said, the procedure is a tool, but you need to be able to make the right choices, and you need to have the support. So they work closely, and I'll let Katelyn elaborate on that, but they work closely with the dietitians. We screen the patients for potential issues. Like I had some patients who ended up having eating disorders, so we refer them to an eating disorder clinic, or somebody who's having issues with depression and anxiety or other issues, we can have them see a therapist. And we also work with our bariatric surgeons. So if somebody needs surgery or we think would benefit from surgery, we would refer them to the bariatric surgeon. At the same time, if the bariatric surgeon has a patient they think would benefit from a revision, let's say, or something like that, they will refer them to us. So it's a little bit complex, and a lot of people are involved because it's a complex disease.
So there's people that get eating disorders post-procedure, or these are people that had eating disorders pre-procedure?
Pre-procedure, hopefully we will be able to identify these patients. That's why it's so important to screen them. So if somebody has an eating disorder, we want to address that. I do have patients who had an eating disorder a long time ago, and they went and they got treated and they got better. And that doesn't prevent them from getting the procedure. And typically, as you said, we work with their providers and we make sure we get clearance that their therapist thinks that they're good to go, they're ready to embark on this journey, and then we do the case.
Because I'm assuming if you're in the midst of an eating disorder, you are not candidate for this procedure.
Exactly.
I'd love a little more detail on how you're actually the relationship you have between all of these different cross-functional specialties that you're working with.
So since we started doing some outreach first and trying to educate other physicians about the procedure because it was new and people didn't know about it. So we went to primary cares and we talked to them about the procedure. So we established a relationship with them, and that makes it a lot easier to actually talk to them when we have a common patient and address things together. And reached out to a therapist who works with bariatrics, and we worked with the bariatric surgeons. It's not always straightforward that you work with the bariatric surgeons. Sometimes people will perceive it as competition.
Yes.
And that's normal. But with time, you establish a good relationship. You understand that we are in this together and we need each other. And the way I think about it, as I said before, we try to offer a lot of different options for weight loss because we want to meet the patients where they are in their journey. Some patients are just not ready or they don't want to go for surgery. So we don't want to just drop these patients. We want to offer them something. While others would benefit from surgery, we wouldn't want to do something less for them or less effective or put them on long-term medications if they would require surgery. So we send them to the surgeon. So we eventually get to see each other's perspective and see where we have common ground. But I also want to say that we talk and work with other specialists. So orthopedic surgeons, I reached out to orthopedic surgeons because many times they have patients who need a joint replacement, but they need them to lose weight beforehand because they're high risk for surgery. So we also do these kind of patients. And I have patients who come to me, infertility specialists. They're trying to get pregnant, but they have PCOS. They want them to lose 30 pounds. That increases their chances of actually having a successful IVF cycle or something like that. And that also is something that we address.
That is fascinating, and that makes complete sense that those doctors would want your help in that. Okay, that's very interesting. So how accessible is ESG right now for patients?
So it is becoming more and more accessible from two standpoints. One, more and more physicians are interested, as you said, in doing the procedure. So it's becoming more available locally because when we started this, people were flying from out of state many times, and they still do, to get this kind of procedure done. Now, most people will have something closer to them where they can have access to the procedure. So that's one issue. And the other issue is the financial aspect of things. So for the longest time, ESG was not covered by insurance. It still isn't, but now we're still seeing some improvement. So the cost is prohibitive sometimes, and we try to find solutions. We work with patients. We work with more than one financing company, so we can actually offer them financing options that would work for them so they can afford it. And also now we're starting to offer it with some insurance coverage. So it's still very early and it's very difficult, and you have to do many, many prior auths to get one approved. But we're working with this process to hopefully next year, when there's a CPT code in 2026, this will be a lot more covered. So that will open it up to many, many more patients, I hope.
I'm assuming it varies around whatever practice, but if someone's listening and they want this procedure done, what's the ballpark if they're paying cash that they would pay for this procedure?
So currently getting this procedure costs around between $10,000 and $12,000 total for the whole program, depending on where you are and what practice and what setting, or if it's being done at the hospital or doing it at an outpatient surgery center. And people offer different kinds of options. So that is basically all inclusive for all the follow-up, and everything we do for a year. Sometimes patients will be able to get a procedure, and then the follow-up will be something that's covered by insurance. So that may make it a little bit more accessible.
And obviously this is different than a regular endoscopy procedure. So tell me what the post-op is like for the patients.
Yeah, it is very different than a regular endoscopy. So, when I transitioned, it was certainly a learning curve. We had some sleepless nights because usually we're trained that you do an endoscopy or a colonoscopy. If the patient has pain, that's a problem. Like, there's a complication or something. But all these patients, because we're doing full thickness sutures in the stomach, they do have pain. They do have nausea. So that is to be expected. So you get used to that initially. But we have a lot of things that we put in place to try to mitigate these. So we make sure that we work with the patients beforehand. So we send them prescriptions for their pain medication, for their anti-nausea medications and such. So some of the things they take before the procedure or the morning. And also we want them to have everything they need ready there at home when they are having the symptoms. So that's number one. We try to work with anesthesia to give them the right anesthesia to minimize the pain and such, and to minimize the recovery. And we are available 24/7 for them. So every patient has my cell phone number. They can call me or text me anytime.
Wow.
Yes, but they don't abuse it, really. I thought they would. They usually don't. I mean, occasionally you get a text message at 3 a.m. that I ate sushi last night and, I'm having discomfort, but that's very rare. But the patients have that comfort or reassurance. It helps with their anxiety that they know that if there's anything going on, they can always reach out. I usually see the patients the next day after the procedure, because I tell the patients, I want to see you when you are at your worst, not when you're doing well. So we set it up in a way that if somebody is having issues with tolerating diet, we can give them IV fluids in the office. If they need IV medications for nausea, we do that. And many times it's just like being there, supporting them, maybe adjusting the medication. And later on, they continue to work with us. And sometimes they just don't talk to me, and then they just talk to Katelyn. They complain, and then she tells me. Or they reach out 7 months later, so they reach out because they're having something. They reach out to the coordinator they started with because they established a good, trust relationship with her. So that's how we take care of it.
At what point in the education process are you prepping them for, hey, you're going to have a little pain after, and this is the process? Where's that fall?
At every point.
Oh,
really.
yes. From day one, day two, day three.
Yes.
Okay.
So like when I have a consult with the patient, I describe the procedure, I tell them about it, but I also tell them what to expect, what's going to happen afterwards. I tell them like how often my patients will require IV pain medications after the procedure and such. And then, of course, we remind them the day off. And then when they come back the next day, so we're always reminding them because sometimes they'll accept pain if they know that this is normal. And we just tell them, if you feel that there's something that you don't feel is right or you think is abnormal, just don't wait, just call me. And that helps a lot.
Yes. All right. For people that are listening, physicians who are thinking, I might want to do this, what were you not prepared for before you started?
Wow. So yeah, it is very different than what we usually do. The procedure itself you learn it. So that's not what I'm worried about. As I said initially, like dealing with the post-op and being in peace with the fact that your patient will be having pain the night after the procedure. But my advice for somebody who wants to start a program, it's really about making sure that all parts of the program are in place before you start. Because you really don't want to start by doing a case and having technical success in the case, but then not having clinical success long-term because you don't have everything else. It's complex, so you want to make sure that you have everything set up. Like, who's the dietitian they're going to work with? How often are you going to see them? Do you have a coordinator in place? Because when somebody calls, like these patients don't call and say, I'm interested, and then, okay, we'll call you back, and somebody reaches out to them 5 days later. They would be somewhere else, getting a consult. So that aspect of how you intake the patients, and then how you evaluate them. Who do you work with? If you have a complication, do you have a bariatric surgeon who can take care of it? Or do you have a therapist you can refer a patient to if they have a psychological or emotional issue? And then just having all that planned before you go for learning the technical aspect of the procedure and start performing it.
Gosh, that seems a little bit intimidating. You haven't even tried the procedure and you're having to get all this set up, hoping that you're going to be successful.
Yes. It takes a lot of work. It takes a lot of setup. It takes a whole team to actually guide a patient from where they are struggling to becoming a success story.
Yes. Okay. So I'm going to move. This has been amazing. I want to move over to Katelyn and talk about some of the dietary stuff. So tell us a little bit about your patient education from a dietary standpoint. when you're developing the pre-procedure action plan?
Sure, absolutely. So I first touch base with our patients about a week or so before their scheduled procedure. And rather than hit them with all the diet information, we kind of break it up into segments. So I solely focus on the first 2 weeks, what that's going to look like, what it's going to feel like. Kind of like Dr. Charbel mentioned, it's not going to be pleasant, and just managing some of those expectations. So we talk about the clear liquid diet that they're on for a few days and what's allowed, what's not allowed. Same with the transition to full liquids, what's allowed and what's not allowed. And, it can be tough taking away people's food choices and sometimes met with some resistance. Generally, these patients understand there's going to be dietary restrictions in the beginning. But when they're in it, sometimes they feel a little bit differently. And so I found it so helpful to I do focus on the diet, obviously, because I have to, and that's vital for their success. But really explaining the why. Why do we want them on clear liquids for the first few days? Why is full liquids indicated for the first 2 weeks? And just kind of leveling with them, like, I don't want to make your life miserable. I want you to have the long-term success that you envisioned when you called Dr. Charbel and said, I want to do this procedure.
So why is it? Why do they need to be on liquids afterwards?
Great question. Healing purposes. And I've unfortunately seen too many times where people are feeling good. It's been a week. They just want something to eat. And those sutures didn't have enough time to heal. And so they don't have that 70 to 80% reduction of the stomach. And long term, we just don't see the results, or they're in excruciating pain because those sutures haven't healed appropriately. So it's really safety, number one. But number two, they're long-term results.
So are you saying that if they eat too large of a meal, they could pop the sutures?
The popping of the sutures, and you may be able to speak a little bit better to this.
It's highly unlikely that you would pop a suture, but we don't want patients to put too much tension and then end up having indigestion and pain. And then if you end up with nausea and vomiting, that can also cause a lot of problems with the sutures. Because
nausea and vomiting, that'd be awful.
It would be.
Yeah.
Just after that, it'd be terrible. Okay, so one thing you didn't say, I was surprised. They don't have to go on a diet prior. You're not having them change their diet before the procedure?
No. So
they can enjoy life. Go eat the cake. Go enjoy your last little bit. Just go for it.
Exactly. If they want to go to the Cheesecake Factory 2 days before their procedure, they're welcome to do so. But they have to begin that clear liquid diet the day before.
Okay, like procedure. A colonoscopy. Okay. And so give me an idea. What do these conversations sound like when you're talking to them?
Oh, goodness. Sometimes I feel bad because you're allowed to have anything clear and sugar-free and non-carbonated. And these are your, 7 or 8 choices. And, so I get lots of questions. Well, can I have this or can I have that? And I found it to be very successful to provide a list of what is allowed. And so frequently I'll just say, refer back to that list on page 6. You have all the documentation. If it is not written down, do not put it in your mouth for safety and healing purposes. And also just reminding them this is temporary. This isn't forever. And, they'll get through it.
So I'm curious, what is on that list? Water, Jell-O?
Sugar-free Jell-O.
Sugar-free. What's the reason for the sugar?
We want to keep the calories low.
Okay.
So with the procedure, initially there's restriction with fluids just from the swelling and the reduction in the stomach size. But as patients heal, there's no restriction in what they are able to drink usually longer term. And so if we don't get them off sugar, that's a very sneaky way to minimize their results.
Oh, yeah, they're drinking Coke and Coke and Coke and Gatorade and all the high sugar.
Exactly.
Drinking all those calories.
So we want everything to be sugar-free, and we recommend no carbonation. The bubbles just feel very uncomfortable after the procedure, and usually takes a few months before people can tolerate the carbonation again. So it's a very boring diet. Water, Powerade 0, Gatorade 0, vitamin water 0, you name it, sugar-free Jell-O, sugar-free popsicles, and broth. That's pretty much it for the first couple of days.
Sounds lots of fun. That's interesting about the carbonation, because carbonation kind of makes you feel a little bit fuller. I would think that would be a helpful one, but no, it's
Some patients get curious and they'll try it, and they learn their lesson the hard way.
They learn that Katelyn was right and they were wrong.
Mm-hmm.
Okay, so I'm sure you're getting lots of calls post-op. So what do those conversations sound like? Are they calling you saying, please, I just really want this?
That's funny you say that. So there's always some patients that I get an email, usually around day 3 or 4 post-op. And this is where they're going into that textbook keto flu. So their body has burned through all their stored carbohydrates and they start burning fat. And in this keto flu, they feel horrible. They're irritable, they're hangry, they have a headache. They just feel like they need to eat something. And so I get lots of creatively worded emails saying, I just can't do this. I need more options. I can't tolerate the protein shakes anymore. And so people can be very, very sneaky about how they kind of ask for permission to eat something. And I just have to politely remind them that we talked about this. We expected this to happen. This is very normal. There's nothing wrong. We just need to stay the course.
You seem so sweet, but it sounds like you're tough.
She is.
You say it with like such a nice voice, but you're like, no. The answer's no. I don't care. No.
Yeah. Yes.
So is there a post-op diet protocol after?
There is. Mm-hmm.
So what does that look like?
So as I mentioned, the clear liquid diet for the first couple of days, and then we transition them to full liquids up until the 2-week mark. And then we put them on soft foods for an additional 2 weeks. And
oh my goodness, this is hard.
It's tough.
So mashed potatoes and mashed potatoes?
No.
No mashed potatoes.
No.
They're no. That's a no on the list.
I should have phrased protein-focused soft foods, because protein is the main nutrient that we're most concerned about and really want to prioritize after the ESG.
So blended up chicken.
So that sounds terrible. And
I
wouldn't wish that on anyone.
People are listening and they're like, can I do this? And
Mm-hmm.
I don't want to eat blended up chicken for 2 weeks.
Right. So, different practices and centers will have different dietary progressions. And we chose to omit the pureed stage. So sometimes people come and they say, well, I already bought some baby foods. And I'm like, oh, please don't do that. I don't want you to eat baby foods. I want you to eat these real foods that are on your list of allowed foods. They just need to be soft enough to mash with a fork. And
like fish.
Correct. Like soft fish, canned tuna, canned chicken in the form of like chicken salad, tuna salad, scrambled eggs. So it's real food that is just naturally softer.
Gotcha. Mm-hmm. So from a nutritionist perspective, how are GLP medications becoming a part of this conversation?
Great question. So it's incredibly variable. I have some patients who are absolutely uninterested. They chose to do the ESG or go forward with the ovarian balloon because they don't want to be on a medication.
I didn't know there was anybody that didn't want to be on. I would sing the song, but on the GLP ones.
Right. So some are very adamant that they are completely uninterested. Then we have others who maybe initially weren't that interested, but it's really cool to see the evolution and their progress, because oftentimes people will get to a point where they've reached what they thought was their goal weight, but now they want a little more.
Of course.
And they're
it's
like,
never good enough.
I could do a little bit more. And, maybe they've kind of, reached the point where, we don't see as much weight loss after the ESG. I mean, they get to a point where they'll level out. And so adding in the GLP-1s can be an additional tool to really help get them where they want to be. And then we also have patients who perhaps the ESG just wasn't the right tool for them. Maybe they have underlying metabolic conditions, PCOS, insulin sensitivity, or insulin resistance, maybe poorly managed type 2 diabetes. And the ESG alone just wasn't enough to get them kind of where we want them.
Interesting.
I think that the right way of approaching this is thinking about all these tools that we have, and then, customizing, personalizing the plan for every patient depending on what they need. Some other patients, as Katelyn mentioned, they start with an ESG and then they have challenges later on. And some people have cravings later on and other kinds of challenges. And it's still a learning thing that everybody's going through, because this field is having a lot more new stuff coming in, and still in the next few years. So we're figuring it out.
All right, I have one last question for you. I think both of you could answer this. I'm curious how you guys get your patients through their anxiety. I'm sure patients come with a little hesitancy and anxiety. Mm-hmm. Maybe you can start, Katelyn. How do you help them with that?
So probably the biggest fear that our patients relay to me is that they're so afraid it's not going to work. They come to us because they've tried everything. You know, they were in Weight Watchers, they did keto, they did Jenny Craig, they were on Noom. I mean, you name it, they've done it. And so they are just so terrified that this isn't going to be the right tool for them. And so it's really just about, you know, hearing them and reminding them that they have this whole team behind them cheering them on. They have a dietitian, they have a physician, they have a nurse practitioner, they have a coordinator. They can call on any of us if they feel like they're not getting the results they want, or if they're, you know, struggling in any capacity. So I think just knowing that they have that support really kind of helps get them through, because it's hard. It's really hard. If I tell them, all my patients, if weight loss was easy, I wouldn't have a job. I wouldn't, you know, we wouldn't be here today. And so, you know, really leaning into the support that they do have and not being afraid to ask questions, and just kind of having that open door policy, so to speak, you know, really gives that support that is so valuable to really calm the anxiety and the nerves.
What about you? What do you do to help them?
So first, I agree. I think that most patients are afraid of being alone on their journey. And then having this reassurance that they have access to all of us anytime. You build it from day one, from when they try to reach out to you, and the coordinator calls them quickly after they reach out, and then they call and they get somebody to answer. So they feel that, okay, this is a place where if I have an issue, somebody will respond to me quickly. But on a different level also, I think being honest with the patients, telling them exactly what to expect, and telling them they will have pain, telling them sometimes they will need IV pain medication afterwards, telling them that these are the results, these are the clinical studies. So, you know, giving them data so they feel confident that, okay, you're not just over-promising. But also patients ask you, like they'll ask you, how many procedures have you done? They'll ask you if you had a complication. They'll ask you, what happens if I have a complication? Where do I go? So being honest and answering all these questions reassures the patients. It alleviates a lot of their anxiety. So they feel like, okay, I feel comfortable with this place, with this person, and with this team, and I think I can do it.
Awesome. This has been so great. Thanks for coming on today.
Thanks for having us.
Really, really appreciate it. Thanks for listening to this episode of EndoCast. Please subscribe to the podcast and follow Boston Scientific Endoscopy on our Twitter, YouTube, and LinkedIn feeds. You can also visit our virtual education platform, EduCare. That's edukare.bostonscientific.com, and choose gastroenterology. The site features over 180 resources, including physician-led educational videos, lectures, case studies, device training videos, procedural tips, and techniques. Thanks for listening. EndoCast listeners, an important disclaimer. These materials are intended to describe common clinical considerations and procedural steps for the use of reference technologies, but may not be appropriate for every case or patient. Decisions surrounding patient care depend on the physician's professional judgment in consideration of all available information for the individual case. Boston Scientific does not promote or encourage the use of its devices outside of their approved labeling. Case studies are not necessarily representative of clinical outcomes in all cases, as individual results may vary. Thank you.